would like to provide any feedback from that session around shifting power to communities? Or is it kind of food for thought?
It's Mark Salisbury here, GP and Weatherby. I can give you a couple of our ideas if you like. But
brilliant.
Yeah, I think we felt generally the public at whole think probably we've got a bit more power than we have got, and a lot of what we do is sort of dictated by what NHS England within healthcare. But probably our main role in giving power back to the public is communicating all the things we know from all the various meetings and emails and stuff going on. So it's ways of communicating with the practice populations and the public that's probably is the best way to hand back power to them. And the other thing we discussed, which was slightly an aside, is just with COVID has sort of complicated everything really, and we can't a lot of the stuff we were planning to improve social vulnerability in Wetherby, you've got to plan for the next couple of years with it being socially distanced and get over these fear of people leaving their own houses. And so a lot of the things we were talking about 6 months to a year ago are no longer really valid ideas for the next, couple of years or so.
Okay, thanks for that, Mark. Anyone else want to provide some feedback? Otherwise, we'll move on.
I was just going to say quickly, Graham, that I suppose for some, we talked a little bit about community projects, and I suppose for real results in an asset based, you'd have to abdicate a significant amount of power and also give some money to a certain group, and you'd have to have the bravery to allow the group to do what they wanted to do, and if it failed the first time, have the courage and conviction to let them have another go at it, irrespective of whatever interference and static you're getting from above, below and to the sides, and just keep persevering. And from a community point of view, if the community say it's an asset, then it's an asset. And if the way we use our metrics, so we should use their metrics. So whatever project we do, if they think it's a success, then it's a success, because we're looking through, I suppose we're looking through success and failure through our eyes, through our prism, really. So we talked a little bit about that, but it does take a significant amount of bravery, and you have to let community members and our lovely residents do it their way. And if it fails, so what? You know, you give them a second stab at it, you learn, and you just keep going on. But you have to abdicate power in a meaningful way. So that would mean that you'd give them a chunk of money and let them do what they wanted to do towards their objectives. And you'd have to be prepared for failure or a resounding success, and then move on to the second attempt, really.
Okay, thanks. I like the word bravery. It's a good word. And also what you've said there around, if the community says it's an asset, it's an asset. Don't, I guess from the centre you could challenge it, but you're right. Just if they say it's an asset, it is an asset. Just believe them and trust them. And what you also said there, if they say it's a success, it's a success. I think, you know, from my perspective of being a data type person, we get a bit hung up on measuring stuff sometimes and counting stuff just because it's easy. But again, trust people. If they say it's good, then it's good. I like that. Any other feedback from anybody else? I don't know if Rachel Cooper's still on the call, if you wanted to just round anything off. If not, that's fine too.
Sorry, are you getting a lot of feedback from me?
Yeah. Okay. Maybe we won't go to our correspondent from Leeds Older People's Forum. Okay. Right. So without further ado, just checking the chat. I think we're good to go. Everyone's back. People are joining, checking emails. Okay, right. So we're now going to look at the health and care workforce as assets. So let me just share this. Hang on. Okay, so you can see that. Okay. So once again, so we've already heard about what an asset might be within our community. And again, just to bring you back and anchor this next section into the age-friendly city agenda, and just give you a very brief reminder of the fundamentals of what it means for Leeds to be age-friendly. So really, the ambition for an age-friendly Leeds is to be the best city to grow old in. So this is something that has been designed and developed in the city, where older people are valued, feel respected and appreciated, and are seen as assets. And actually, this particular slide hopefully will be useful for the next exercise. So those 8, just when we're looking at asset mapping, the age-friendly domains, could you theme any assets around these domains around, we've heard about transport in Wetherby, employment and learning, housing, that sort of thing. So these might be some good kind of themes or headings that we can use when we're doing some asset mapping. So hopefully that will kind of then anchor that back in that age-friendly Leeds strategy and action plan. So without further ado, so I am very pleased to be able to hand over to one of my colleagues, Anna, and also David Smith from Crossgate's Good Neighbours, and they're going to talk to you about carrying out an entirely virtual asset mapping exercise. So I'm kind of hoping that Anna is there. So say hello, Anna.
Hi everybody, I'll just quickly introduce myself. I'm Anna Masarich, one of the project support officers within the local care partnership development team, and like Graham said, I support Crossgate but also Seacroft and York Road. Does David want to just quickly introduce himself?
Yes, hello everybody, I'm David Smith. I'm a trustee at Crossgate's Good Neighbours, and I've been working with Anna obviously within the Crossgate's LCP.
Thank you, David. Great stuff. So I suppose we'll get started. So I think one of the first things, I am going to turn my camera off just to make me feel at ease a little bit, and I do apologise if I do speak a little bit quickly, but all this will be passed over to you anyway. So I think one of the first things to start on is what is asset mapping really? And so basically asset mapping helps capture, helps capture aspects of the community from a physical, social, emotional and cultural perspective, and is also an essential step in transforming how services and communities work together. So basically it involves creating a map of the resources and skills of individuals, groups and organisations within a predefined boundary. But one thing you do need to remember is that I know we have LCP boundaries, but some organisations will fall out of your boundary. So just example, some citywide services like Age UK Leeds, and that's one example. Please could you go to the next slide, Graham? Great stuff. So I thought it'd be really neat to kind of just show you as a roundup on like how the asset mapping journey sort of started at Crossgates. So Crossgates local care partnership formed in a virtual sense in March. So we kind of formed in the lockdown, which was quite challenging, but we've managed to come together quite well. So then in one of the meetings, partners had sort of mentioned around the fact that they wanted to explore the assets in Crossgates to kind of help them identify, different things that are going on in the area. And then helpfully, David Smith created an amazing extensive list on an Excel spreadsheet with lots of different fantastic assets and a range of different sort of assets around that, which I'm going to kind of go into in a bit more detail soon. And then from that, we kind of had a little sort of group meeting with myself and Carl, who's also a part of our team, kind of just trying to get the third sector's voice within LCPs. And we just kind of just discussed basically what we wanted to capture, as in people, because obviously people are really important in terms of assets. So like, for example, David Smith is an asset of Crossgates and is fab. Obviously places, community groups and spaces, you know, different places of worship. Like Graham was saying earlier on that last slide before we started, those different points around the transport are really, really useful to think about as well, of how people are actually getting about across sort of the sort of localities. So that was that, and then we sort of thought the best thing to do is how are we gonna display it really. So my first idea was to draw a map, but obviously it's really hard to kind of show the map virtually and sort of continue. So we kind of decided on Google Maps. So we got a load of layers, and then I kind of in the background just started to add what David had added on, and then eventually we then shared it with the whole Crossgates local care partnership. To all the partners, and so this included sort of like the Google Maps, so we like let everybody explore that and kind of gave them a little show around it, and then we discussed people as assets. So this was mainly well, this was on a PowerPoint slide, but this is going to be transferred to an Excel spreadsheet, and then we also looked at social media, because I think you know, like I know that in my local area we have all different, you know, social media groups and pages where lots of information comes to light in your local sort of patch. So it's just about how we use those services really. And then the next thing was around upskilling David to use the Google Maps to be able to add different assets along the way. I don't know if there's anything you want to add, David, to any of this so far.
Well, yes, I think it is very useful having an actual map as opposed to just a spreadsheet, an Excel spreadsheet with the assets on it. I particularly appreciate the map because of the problem with the different boundaries we have with the LCPs, the neighbourhood networks, the NHS neighbourhood teams, and the LCC wards. All have got different boundaries, so sometimes you don't know where you are, and it's good to have a map just to look them all up actually.
Great, thank you, David, for that. Yeah, I agree. I think having the visual aid of a map is fantastic. So please, could you go on to the next slide? Fabulous. So I suppose we always like and come back to why. So I suppose why asset mapping? So I've sort of noted down a few, well, more than a few reasons, several reasons, but there'll be absolutely loads of these, and you'll probably be thinking of some already. So I suppose first one, it allows linkages, duplications, and gaps to be identified within different areas. It allows people to think positively about a specific place, and so kind of that awareness and empathy of how other people experience their community. Asset mapping has the potential to highlight where inequalities exist as well. It promotes opportunities for the asset-based community development side of stuff, community engagement and volunteering as well. Asset maps are a great way of bringing all different local care partnerships together and utilising all the resources in a better way. And then obviously with the PHM work, obviously we're sort of like starting with the frailty cohort. As you can appreciate, a lot of the communities come from a very, well, you know, they are one of the most complex group of people that we're working with, and I suppose it's really useful to be able to map those assets so we kind of know, you know, what's around and we can kind of use the resources. And then knowledge of assets helps us understand data in regards to the need or outliers, which can be different to what we initially thought. So I suppose that kind of thing is around, you know, we've all kind of been given our data packs, and we'll have seen like the sort of immediate outliers, what we kind of need to be working on. But sometimes asset mapping will highlight some of that as well, which is really useful. So please may you go on to the next slide. Thank you. So now is kind of a bit of a Q&A with David. So we thought this would be quite a neat way of kind of showing you the experiences, not just from obviously the local care partnership development team, but from obviously David, who has been working on these maps with me, within obviously being a member of the Crossgates Local Care Partnership. So I'm just going to ask David some questions, and then he'll be able to answer. So question 1, David, how have you found virtual asset mapping?
Well, getting to know how to use Google Maps does take a bit of trial and error, actually. It's a bit fiddly to use it, but you just got to persevere. This applies to people who are adding layers or items to the map, obviously. If you just want to use the map to look up various assets or locations, then it's really quite easy to use the Google Maps.
Thank you, David, for that one. So question 2, how do you find using Google Maps for asset mapping?
Well, I think, especially from the point of view of a local care partnership, the whole point of the LCPs is to cover all of the assets and organisations within a community. We had a great presentation previously about ABCD, and I think the Google Map really is the embodiment of ABCD, really, because you can put all of the community assets on it, from the social groups, leisure groups, to the green spaces that you've got, your places of worship. We're even thinking of putting local Facebook groups on it if we can find a way to find them all. So it's really got all of the community assets on it. I think it's a great thing for an LCP. Great,
thank you, David. Oh, so you've kind of answered question 3 there, which was sort of how important is asset mapping for a local care partnership. But that's fantastic anyway in itself. Question 4 then, which assets do you think are important to identify?
Well, I think it's mainly, from my point of view, it's the assets that are going to get people involved in their communities, and making sure that all the assets in the community are available for the people to use as well. And just working on the asset map really helps you to find out all the assets, and hopefully to present them in a way that people can go to that map and find out what they need from it.
Great, thank you so much for all that feedback, David. It's fantastic. If we can go to the next slide, please. So obviously when the slide deck gets shared and things like that, there is a link that I've added on to this presentation at the end, so you can kind of have a little nosy and look around what we've done in terms of Crossgates. Obviously we've not finished it at all yet, it's just sort of it's on the start at the moment. So I just thought it'd be nice to show you some screenshots really of what the asset map looks like, because when everybody else gets the opportunity to do it, you'll have a very similar look to your screen. So I suppose the first picture just highlights that we've put the local care partnership boundaries in, so they're kind of like in red. So you can see like the yellow one specifically is Crossgates, and then because obviously with East Leeds being quite well connected, I have highlighted there in blue Seacroft, and then in sort of like a red colour York Road, because like I said earlier, a lot of different the boundaries aren't always like what's in them, so you've got to think about other services that are outside. So for example, like Crossgates Good Neighbour, where David's a trustee of, that's heavily used in Seacroft as well as Crossgates. So it's just being mindful of those services and how they work basically. And I suppose the next screenshot just highlights the fact that we can put PCN boundaries on, which is the primary care network, which is the blue one, and then also the Leeds neighbourhood teams. So obviously with Leeds neighbourhood teams, again, like with some of the areas, they can cross over into quite a few. So I think Seacroft is probably quite a good one to mention. Oh no, sorry, York Road's a good one to mention for this one. So with York Road, they'll have the neighbourhood teams from Seacroft and from the Chapel Town area. So it's just being mindful that actually it's not just you know, Crossgates or York Road or Seacross specifically that have that, you know, that group of people. It's just being mindful, like, again, that they are slightly out of the boundary, but that's okay. Please, could you go on to the next slide? Yep, so the next one, so this is just a bit of a screenshot of quite a few different layers that I've added. So obviously you've got the LCP boundary there in the background. And then what I've sort of tried to highlight are different things that myself and David have put on around healthcare. So that looks into like hospitals in the near area, GP surgeries, dental, and all that kind of stuff. So they've all got different sort of highlights. So the dental one, I've tried to use a tooth, which you can see kind of on the map. And then obviously healthcare kind of like a cross. And then you've got the care homes. You've got education, green spaces and parks, and then also places of worship on there. Like I was saying earlier about sometimes being mindful of boundaries, the second screenshot kind of just highlights that the school, Crossgates Primary School, is actually, if it's hard to tell on this, but it's actually in the York Road boundary, which is really interesting. Although it's called Crossgates, so again, it's just like I say, it's being really mindful, you know, of the different sort of boundaries and where things lie. Please, could you go on the next slide? Fab. So yeah, here's the link. You will have to copy and paste it into your browser. I don't think it'll work just to click on it. But I suppose just some key considerations that I think I'd like to bring to light for when, you know, if anyone gets a chance to do it in the future. So asset maps do need regular updating, and the great thing with them is that, like, if you map on, say for example, Crossgates Good Neighbours or a church or whatever, you can actually add in there in text like different groups that they run. So if it's a coffee morning, if it's like an exercise group, you can add all that in, which I think is superb. But obviously you can be mindful that sometimes these services changes. Obviously COVID changed pretty much everything and stopped, you know, all the sort of like outdoor activities, you know, going out into the community. So that's one thing I suppose we do need to keep mindful of, and some services do go, some services obviously get new services. So there's lots of different things that need updating on it quite regularly. Also, it's really useful to have another tool as well as the Google map, kind of like an Excel spreadsheet or something like that, to collect other assets which I believe aren't appropriate to add on a map, which everybody can see. So such as individual people, that's a really important one to probably keep sort of in the background a little bit more, and social media as well, because I think with the sort of like Google Maps, there's only so many layers you can add. And I suppose having a list of key social media contacts and community groups would be a really good thing to have, probably on an Excel spreadsheet. So I suppose I hope, thank you very much everyone for listening, and I hope that's been a bit of a whistle stop tour of kind of like Crossgates asset mapping, and if anyone's got any questions, please feel free to ask.
Yeah, so I just echo that. So thank you very much to Anna and David. That was fantastic. As a map person myself, you can't beat a map. Being able to see stuff and switching layers on and off is and zooming in really helps. So yeah. So any questions about that? Okay. Thank you very much, Anna. Top job.
Thank you.
Okay. So we have managed to catch up a bit of time. So the next thing that we are going to do is just introduce. Now I'm wondering, we do have a bit of extra time. So this is going to be a section for Neil. Just thinking aloud, do you want to do a bit of a group exercise around this, Neil, or should we keep this for some group work outside of this main meeting?
Psychosocial.
I think it would probably be good to just kind of land it as a concept, really, Graham, and then instead of doing the group exercise here, then there was a plan for this to feed into the follow-up meetings in between the workshops. So I think we can just land it and then work through it in those follow-up meetings and not have a group session today.
Okay,
that's just kind of my opinion there.
That sounds like a good opinion to me. Okay, so I'm going to hand over to Neil, and most of you will know Neil, but he can introduce himself. So yeah, over to you. And when you need the next slide, just say next slide, please.
Cheers, Graham. Really appreciate it. Yeah. So, this is a kind of a continuation, really, and a way of organising or potentially organising what asset mapping from a workforce perspective could look like in terms of some of the follow-up actions and homework that we're going to be working on over the next few weeks. One of the main things that I want to open up with, though, is an apology around the title of a biopsychosocial approach. I want to make specific reference to it. It was a presentation that I'd done for the Tenfold group, which is now Volition, and I introduced I mentioned around the biopsychosocial approach, and there was a kind of immediate critique of the phrase, and we know that in terms of partnership work and that language that we use, and we've spoke about it before, and Rachel's alluded to it in her presentation, and Hannah alluded to it in her presentation as well, about the importance of language. So I really, what I want to say is kind of an apology there, but there's a reason why I want to take hold and kind of keep that biopsychosocial title, really. Since that previous presentation, we've used phrases such as a holistic approach, or a whole person approach, but there's a reason, just in terms of intervention design and partnership work and partners understanding their stake within an intervention, that I just want to keep hold of that biopsychosocial title. So I want to open up with an apology, but yeah, I feel like it'll be useful in terms of organisation, kind of organising that next step in terms of intervention design. So next slide, please, Graham. So the biopsychosocial approach, what is it? I'm 100% sure that there's people in the room that know exactly what this approach is. So I do apologise if this is kind of going over old ground. But again, mindful of that experience with the presentation that I've done with other organisations, I just feel like it's important that if we introduce a kind of an approach, that we just give a little bit of background, kind of a bit of background knowledge around it. So what is it? You can see on the diagram on the left-hand side there that the central tenet to this is people's health and health-related quality of life. And what are the determinants? What are the factors that influence a person's current health-related quality of life? And this is backed by research. It's a theory that was introduced in the 1970s and that is continually being built on and kind of developed. But it's that real appreciation that it's a move away from perhaps a biomedical model where it's simply health is really defined by a biological status, and to understand the sociological and psychological aspects and influences of health. So when we're thinking of health, it's split up into three domains. The biological, which could be age, gender, or genetics, and specifically comorbidities. So those health states really that contribute to someone's health-related quality of life. And for the frailty kind of specific focus on this, then I'd just refer people to the EFI model that was introduced in the last workshop, which is that electronic frailty index, which is a way of essentially categorizing whether people are either mild, moderate, or severely frail. And then the psychological aspect of health. So again, specific for maybe an aging population or specifically the frail population, instances and experience of isolation and loneliness, which is what Rachel has just given some brilliant background on. the likes of worry, stress, anxiety, depression, and what influence that has on a person's health-related quality of life. And what we've uncovered really in some of the people's voices work that we've done in this work, in this homework previously, around that feeling of safety and security, and the impact that that has on somebody's health-related quality of life. So again, in terms of the specific psychological aspects relating to frailty, then I just refer people to that EFI model. And then the sociological aspects, which we've touched on really importantly and kind of strongly in the previous presentations earlier on today, around the importance of that kind of family and friends support network and those opportunities for social connectedness and whatever is meaningful to people in terms of social connectedness. And we also know that from a sociological perspective that deprivation and poverty has an absolute influence on someone's health-related quality of life. Linked in with that is the physical environment and how accessible the environment is, the built environment, and the opportunities for green space, access to green space, and again the influence that has on a person's health. And again, specifically to frailty, refer people to the EFI model in terms of I've highlighted the word in kind of quotation marks there as deficits because it makes me shudder when I say it, but it's the terminology that is used, unfortunately, for frailty. So the key bits that I want to kind of allude to in that model on the left-hand side there is the arrows around the outside. So the links between the biological, the psychological, and the sociological. These things work in they're a dynamic thing, and I was what struck me about what Rachel said around isolation and loneliness, that it's context specific and it's time specific, and it's a dynamic thing that changes over time and changes as a result of context. And it's this interplay between the biological, psychological, and sociological that determines people's health, and that's not a static thing. So we just want to make sure that is, that kind of that context is landed there. So Graham, next slide, please, just to give a little bit of a case example of that biopsychosocial approach. So we'd just like to introduce Charlotte. So Charlotte was known as Totty to her friends, and she was known as Gran to me. So I personally come from a physiotherapy background, so that was what my that was kind of my kind of understanding of this biopsychosocial approach, and it was something that we used to use from a rehabilitation perspective for people. Sorry, I've lost my trail of thought there. So I come from a physiotherapy background, and I was wondering whether there was some case studies from my work and background that I could bring, and I actually thought that that my gran was a perfect example rather than a case study from my physiotherapy background. So for my gran specifically, she lived with a clinical diagnosis of COPD. She had coronary heart disease. She was hypertensive. She was low weight, and what I actually missed from there as well is that she was osteoporotic as well. So she lived with osteoporosis. So that was kind of her biological state as such. And obviously relating to that, there was a real need and a real there was a need for support from the system because she was a complex patient in terms of her biological status. From outside looking in, from me, there was certainly evidence of worry and anxiety around safety and security, and that was absolutely linked to that, to the complexity of her conditions, really. In terms of sociological or social health, my gran was a widow. She was very lucky that she had close family, and by close family I mean that geographically we used to live around the corner, but also in terms of their relationship. So she was very lucky in that sense, and she also had a large friendship circle. And I think that the picture that we're trying to paint here is that in order to contribute to my grand's health related quality of life, of course, because she was a complex patient that there was a need there for good and effective health service provision. Of course, there was that need. But what I would say was, in terms of what was really important to me, Gran, is that she loved to play bowls twice a week. That gave her week structure. It gave her the opportunity to connect with her friends and her peers, and it gave her a little bit of purpose around their week. Unfortunately, because of her condition of COPD, she couldn't actually physically play bowls twice a week. But again, due to that friendship circle and that close family circle, someone would collect her and take her to bowls. And even though she wouldn't play, she would mark cards, she would make cups of tea. And again, that gave her purpose. So she was very lucky in that sense that she was able to she was able to socially connect, and she had those support systems already in place that had that real contribution to her health related quality of life. Now, in terms of a physical condition, if she had exacerbations of COPD and she needed a hospital admission, it would have a massive impact on that worry, that anxiety. Of course it would, and it would create a barrier for her to be able to engage in those sociological kind of aspects of her life. So being able to go to bowls, and then again there starts the cycle of feeling isolated. And feeling lonely because she wasn't able to engage in those activities. And all of these things on a constant moving and dynamic scale contributes to my grand's health related quality of life. So I think it's just hopefully a bit of a neat way to understand that interplay, really. And the reason why we want to introduce this really is to understand the stake that different partners within a local care partnership and within this intervention design, a stake of what each partner have got to play in the biological, in the psychological, and in the sociological aspect. Next slide, please, Graham. Okay, so what's the reason why we're landing this in terms of an approach for asset mapping? So as we know, in terms of its links to frailty intervention design, we know that the greater number of frailty deficits increases that complexity of need, and our frail population have a greater relative risk of low related quality of health related quality of life. And when we consider the frailty fulcrum that was introduced in the previous workshop, we know the frailty as a state it's multifaceted, and as such it brings into that biopsychosocial kind of contributions to health related quality of life. So interventions that are designed needs to be similarly multifaceted, and we need to have that approach, really, that well-rounded approach, and based on that partnership, that well-rounded approach to intervention design and delivery needs to take place. And we can only do that in a really effective way if we know what assets that have a contribution, that have a potential stake into each of those aspects of the model. We need to know what is at our disposal, essentially, and what's the art of the potential in terms of the assets within our community. And in terms of the lead frailty outcomes, this is that kind of golden thread, really, through that public and public engagement and co-design work that was done before all this started. What was important to people living with frailty in Leeds. And one of the important things was around living and aging, dying well, defined by what really matters to people. And what we're looking to do, because that is a holistic and well-rounded way of looking at things, the way that is going to be measured is around health-related quality of life. And that health-related quality of life measure includes domains such as mental health, social health, physical health in terms of function and your ability, your physical ability to be able to engage in activities of daily living, but also physical health in terms of symptoms and that kind of experience of symptoms, and also an overall health. So we're not looking focused here, we're looking at the broader picture. So as such, if that rounded picture is important to people, it's important that we design interventions and design kind of support networks that really allows that to flourish, but then also it links to how we're going to be measuring things as well. So next thing, Graham, next slide. This is going to be the group exercise that we're going to be looking at in terms of our homework, really. So as we know, the brilliant work that's already taken place in the previous weeks prior to this workshop, each partnership has taken that time to gather people's voices about what's important to them, what the role the system could and should play in this and in terms of aging well, and also what could be done better to live and age well in their community. So with that picture in mind of what people have said, and also understanding now this concept of that biopsychosocial approach, what we'd like to do is for each partner within the local care partnership kind of population health management team at the moment is just to identify what aspect of that approach, that biopsychosocial approach, that you primarily align to. And as an extension of that, how and to what extent does your role attend to some of the aspects of that biopsychosocial approach as well? The next bit that we'd like people to look at is with your potential cohort in mind, and I know those conversations have already gone into some detail, which is brilliant at this stage. What are the other workforce assets that are on your patch that could contribute to either to each individual aspect of that biopsychosocial approach, or have the opportunity to contribute to all? Now, kind of I come from an exercise science background as well, before being a physiotherapist. So a partner and an asset of the community that speaks to that is Active Leeds. And Martin, I'll kind of sing your praises here. I think that is a perfect example of how exercise and physical activity can have a positive impact on your biological state, but also opens up opportunities to contribute to, we know the contribution that physical activity can make to your psychological well-being, but also the opportunities that creates in terms of engaging with people, engaging in groups and what have you. And it's a really neat example of how there's a potential asset within your community that can attend to all three. And then after that process, we'd just like a period of reflection, really, for as a group on workforce assets at your disposal. Are there any gaps? Do we need to kind of consider what perhaps new assets need to be created, or who else on your patch could contribute meaningfully to this work? Do they need to be part of this working group, or do they just need to know about this work, and as such, when the need presents itself, to link in with those relevant assets in your community? So that's something that we're going to be picking up in our local care partnership meetings and follow-up meetings over the next couple of weeks. So just to land that one early there. But if there's any questions around that biopsychosocial approach, then please let me know. What I'll ask for in terms of the the minutes and the follow-up is that we link just some key papers, really, some research papers around the biopsychosocial approach, just for some background reading if people are interested, or if people would like to try and get to sleep a bit better at night, then that might be useful. So that's it from me.
It's fantastic. Thank you very much, Neil. Right, so I'm getting a bit of feedback now. So we're bang on time. I've checked Slido and there are no burning questions appearing on there. I think we've used the chat pretty well today. So thank you to all the presenters that we've had so far. Just to reiterate, so there's the homework that Neil has introduced there, which will be taken up with your meetings, your LCP meetings outside of today. There's some other bits that we'd like you to have a think about, and the LCP development team will guide you through this. So in terms of the next workshop 3, which is on the 3rd of September, that's going to be very much focused around data and measurement, and basically how do we know we're making stuff better. So the question for you guys in your teams is, you've got your data packs. Have you got all the data that you need. I know I've been busy working, getting stuff around, cutting the data into index of multiple deprivations and providing some stuff. So have you got everything that you need? Is there more stuff that you need in terms of data? Is there more input maybe that you need in terms of medical conditions? Do we need to get some different people in the room to help you understand certain things? So there's a question, there's a bit of homework there about data. Just come through the LCP development team or come straight to me. And then also, we'd like you to start having a look at the asset mapping. So there's some help available. Can we start to pull together a Google asset map for all of the LCPs in this wave of the workshop? So there is some support available. There is a training video that Anna has put together as well, so we'll make that available. So there's plenty to be going on with. So that's kind of the end of where we are for today. Again, timing has worked in our favour. We've picked up a bit of time. I know some people have got to go at 12:30. So I'd just like to say thank you once again to everybody who has stuck with it this morning. We have a couple of issues with Teams to sort out, but generally everyone has remained on the call, which is fantastic. So just before we go, is there anyone that has any questions? Feel free to just unmute yourself and come on the call.
Karen's got her hand up, I think.
Yeah, hi. I was just wondering about I put it in the chat, the asset map that you've created. Is it available for citizens or is it just for the LCP? Because it's an asset in itself, isn't it, that map? It's fantastic. So if people could just access it themselves, I think that would be really helpful as well.
Yeah, I mean, Anna, do you want to make a comment about that?
Yeah, I suppose currently it is in like the first initial sort of stage of kind of getting it together and stuff. But yeah, I do think that's a really good idea, because I suppose one thing about asset mapping is kind of bringing it to the citizens and the people that live in the communities to kind of, you know, have their say on it as well. And I suppose they'll have a lot more knowledge than people who don't live in Crossgates, for example. So yeah, I wonder if that's something we can do, maybe like when we did our sort of feedback earlier on, we met with Crossgates Good Neighbours to talk to them about like the aging friendly stuff. So maybe that could be like a forum, a way of doing it in these times with lockdown.
And I'm just thinking about the Facebook groups as well. You could put a link on it from onto Facebook groups, couldn't you? Because I think it might be that people might want to access them themselves rather than going to someone else to be referred to something. You know, if it's such a fantastic resource, people could do that, couldn't they?
Yeah, definitely. Yeah, I think once more stuff's on it, it'll be, I think, a bit more helpful for people. But yeah, I think that's a really good idea, just being able to share the map for the citizens, and then they can sort of see what is there, and they might kind of then get that, they might be able to signpost themselves then to
or come up with other stuff like you said, Anna. So yeah, cool.
Thank you.
The other thing that we're looking at, that we'll probably be talking to all local care partnerships about in the autumn, we're just rethinking our communications around local care partnerships. So aware that we've been pulling together the digests for you as a group and sharing what's been going on, which I think has been particularly helpful during COVID, where there's been lots of changes to services, but it's just made us think about, well, what's the stuff that we would want, or that you would want to get out there for the local community around your local care partnerships, and is there some way of helpfully sharing some of that? So we're looking at what might a local care partnership website look like, and having very clear sections where you can just go straight to what your local care partnership is and what's going on there. So again, thinking about that map, you're right, Karen, it is a huge asset, and there's absolutely no reason why we couldn't put a link through to that if we are developing a local care partnership page for each of your areas as we go forward. So yeah, definitely something to think about how we share that.
Fantastic. Okay. Well, I think
Sarah's got her hand up now, Graham. I don't know if you can see the raise hand function.
Hi,
yeah,
it's Sarah here from Leeds Older People's Forum. I just wanted to just draw a connection really between age friendly, which has been talked about, and the assets. And just to say that if people, when they are asset mapping, discover places that could perhaps be useful for them to find out a little bit more about what being age friendly is and how to be more accessible to older people or welcoming to older people, or in fact people living with dementia, then we can help with that. So we've got resources and sign up schemes and things that Rachel mentioned. So it's just putting it out there that if people are interested in that, they can get in touch with us, with me at Leeds Older People's Forum.
that's great. Thank you very much. So I can't see anyone else with their hands up or anything else in the chat. So I'm going to call an end. So the next workshop is on Thursday, the 3rd of September. There'll be a focus around data. Hopefully everyone won't groan. It'll be exciting. It'll be interactive. There'll be a bit of me, a bit of Neil. So we'll try and make it as cool and as fun and as interactive as possible. And there'll obviously be a big chunky bit of feedback from the homework that we've just set as well. So there's plenty to be going on with. If you've got any feedback on how this has worked, then please do let us all know. But with that, thank you very much, and have a good afternoon. And thank you all for being here.
Thank you, Graham. Thank you very much.
Thank you, Graham. Thanks, everyone.